Hello and welcome back to Pharmacology with Dr. Sokolow, and moving on to the last module of Principle of Pharmacology, and all those principles apply to special populations such as the pediatric population and the geriatric population. So first, let's talk about the pediatric patient and the neonate and the infant. As you know, infants are more sensitive to the equivalent doses, and the reason why is because they have alteration in their absorption. They have prolonged and irregular gastric emptying, and also the gastric pH may be a little bit higher, so it's above 4, while in adult it's around 3. And so pH is important for the absorption and crossing the membrane. So drug will be the absorption of drug will be altered in that way. Distribution, which relate to protein binding. Protein binding is limited in infant, and therefore there is more free drug. There is an increase in free drug, and because the free drug is the one that is responsible for the effect, you're going to have an intensified effect in infant. Blood-brain barrier is not fully developed, and therefore the brain of infant and neonate is not as protected as the adults, and so you can have an increased effect in drug that has to cross the blood-brain barrier and reach the central nervous system. Hepatic metabolism, same thing, their metabolizing capacity is low, and so the metabolism is going to be slower, therefore the effect of drug is going to be prolonged and higher risk of adverse effect. Renal excretion, the renal blood flow and the glomerular filtration is low, and so therefore excretion is also going to be slower, and the drugs are going to remain longer in their system. By the age of 1 year, most of the pharmacokinetic parameters are similar to the adult, but of course you have to adjust the dose based on their body weight. So here is the equation to determine the dosage for a child, which is the body surface area of the child multiplied by the adult dose and then divided by 1.73 meters square, which is approximately the body surface area as an average adult. And so here you see you have two curves on this figure, and you see you have the plasma drug level of an adult and an infant after IV injection of the same drugs. And so you see that the concentration of the drug in the infant remain longer in the system than in the adult. And so that's why you have to adjust the dose in children. And you don't need to know this equation for my class, but I'm pretty sure for your pediatric class in the summer you will need to know it, but I'm not going to question you on calculation at this point. Here again, these are the important conversion rules. How do you convert gram into kilogram, and how do you convert the patient weight from pound to kilogram, or the patient height from centimeter to inches, because those equations required the body to be expressed in kilogram and the height in centimeter. So again, I'm not going to question you on so on this slide I have important conversion rules. Again, you won't be tested on my exam on calculation, but because they are important conversion rule, I feel like the more you see them, the more you get familiar with them, the better it is for you. And it's very important to know how to convert gram into kilogram, centimeter into meters, milligram into gram, microgram into gram. So these are the conversion factor, and also how to convert the weight of a patient in pounds into his weight in kilogram. And same thing, the height of a patient in centimeter, in feet or in inch into centimeters. I'm grew up in Europe, so I'm very familiar with the metric system. but in all those all the doses in medicine are in milligram, they are not in ounce, so you have to have an understanding of what it means. Something that is 5 milligram, or a drug that is prescribed at 1 gram, so you have to understand the difference, and also how to convert the patient body weight from pounds to kilogram, because all those equation requires the pounds to be in kilogram and the height to be in centimeter. And now the other population that is an important population nowadays with the baby boomers, this is the geriatric population. And because those patients are usually polymedicated, we have to pay very attention to their regimen. As you see, they are 7 times more likely to have adverse reaction in elderly. This adverse drug reaction represents 16% of the hospital admission in elderly. 50% of all medication related deaths are in elderly. And this is not just direct results of aging on the body, but it's also because they have reduced renal function, they have polypharmacy, they tend to be sicker, they have not just one pathology, but they have multiple pathology. They can have hypertension, diabetes, they can be obese, so they have multiple pathology. And then also they are using drugs that has a narrow therapeutic index, so those drugs because of their polymedication and their condition, sometimes they're required to use those drugs that may be stronger, but they have a narrower therapeutic window. So you remember, it's like the window between the effective concentration and the toxic concentration, and if that window is really small, you have a greater risk of toxicity, especially in patient who has a reduced kidney function or a reduced liver function. There are more individual variation in elderly. In long term therapy, they don't necessarily have the adequate supervision. They get older, they don't know, or sometimes they also cannot read their label on the drugs, or they get confused which drug they took and which one they haven't taken yet. And also sometimes they can be they have poor adherence. We know that elderly tend to be stubborn also, and sometimes they don't want to take their medication, and so the poor adherence also results in not adverse drug reaction, but more like less efficacy of those medication in the geriatric population. And so, for the infant and the newborn, there are some pharmacokinetic changes in the elderly. For them, the absorption rates may be slower. Their GI system is slower now, because of overuse, and they are older, and so all the muscle cells, are not working as efficiently. The smooth muscle cells are not working as efficiently as in a younger adult. The distribution, because they have an increased percent of body fat, the response to the lipid soluble drug is reduced, because the drugs is going to get stored in those fat tissue and not being distributed, so you're going to have a reduced response of those lipid soluble drug. Some has a reduced percent of lean body mass. They have reduced total body water, and therefore the response to water soluble drug is going to be increased, because if you have less water but that drug stays in that water, the concentration of that drug is going to be higher. Then you can have reduced concentration also of their albumin, and you remember only the free drug is the one that is active. So if they have less albumin, you're going to have more of the free drug, and then higher risk of toxicity. Metabolism, there is also individual variation in their metabolism, also interaction with those CYP enzyme. And then excretion, which is the most important cause of adverse reaction in the elderly because their kidney function is reduced and most of the drug are excreted through the kidney. You can have, drug accumulation secondary to reduce renal function. If those drugs are not eliminated from their system, therefore the drug remain longer in the system, and you have a drug accumulation and increased risk of adverse reaction. And so lastly, you can have changes in pharmacodynamic in elderly. You can see some alteration in receptor properties, which may underline the altered sensitivity to drugs. So for example, if you have a reduced number of beta-adrenergic receptors, so you have less receptor for the beta blockers, and so that means the drug is going to have less site of action to act. You can have reduction in the affinity of those beta receptor for the beta blockers. So if you have reduced affinity again, you're going to have a reduced effect of those medication. Another thing that is important to monitor in elderly is the renal excretion of the drug. And this, you do it by assessing the creatinine clearance, because if a drug is metabolized by the kidney and their kidney is impaired, you can have an increased risk of toxicity. And so in conclusion, geriatric population are at increased risk for drug-induced adverse effect. And it is our efforts, as healthcare provider, to help them, and we need our effort are needed to optimize the drug therapy in elderly. Otherwise, there will be no country for old men. And saying that concludes our module on pharmacokinetic, pharmacodynamic, and principle of pharmacology. I hope you enjoy the topic, and I will answer your question during the class discussion, during the Zoom discussion.